A warm welcome, my dear students. It is a really pleasurable moment to discuss about the basic airway management and endotracheal intubation, a skill that is required in managing the patient coming to the emergency room or coming in to the casualty room with a compromised hemodynamic condition or in cardiovascular collapse. So also in the intensive care unit in order to maintain the patent airway and respiratory support. Endotracheal intubation involves introducing the endotracheal tube through the oral cavity or the nasal cavity into the trachea to maintain the patent airway for the ventilation and oxygenation purpose. And its endotracheal intubation is required for respiratory failure, symptomatic hypercapnia type 2 respiratory failure, treatment of symptomatic hypoxemia type 1 respiratory failure, or airway protection against the aspiration. Sometimes it is required to provide the effective bronchoalveolar lavage. Contraindication: we cannot do endotracheal intubation in awake patient. When it is possible to manage the airway with the non-invasive way or less invasive way, it is better to avoid the endotracheal intubation because it itself is associated with the complications. So, as again I am repeating, endotracheal intubation is introducing the tube into the trachea to provide an open airway. What are the equipments required? It is essential to have intravenous access. For that reason, the IV cannula and the IV fluid, IV set, then monitoring of the heart by the ECG, so multi-para monitor, pulse oximeters, which are essential for monitoring the hemodynamic condition of the patient. For carrying out the procedure of endotracheal intubation, there should be a working suction apparatus, because invariably orotracheal secretions will cause the partial obstruction, and even they will act as a hindrance for hindrance for endotracheal intubation, and even aspiration or regurgitation of these into the lungs will lead to the lung injury. Accessory airways like oropharyngeal or nasopharyngeal airway and bag wall mask, oxygen source, appropriate size endotracheal tubes, endotracheal tubes of various sizes, the stillet, boozing, syringe to inflate the endotracheal tube cuff, laryngoscope with appropriate blade and handle, and adhesive tape to fix the endotracheal tube after the intubation. So the kit should contain all the things that are required, like endotracheal tube, the endotracheal tube, laryngoscope, adhesive tape, syringe. Apart from the equipments, what I mentioned previously. An ideal endotracheal intubation kit contains tracheal catheter, 12 size suction catheter, 14 size suction catheter, 14 number catheter, 14 section catheter, then connecting tube, syringe, gloves for personal protection, endotracheal tube holder, laryngoscope blade, and basin tray. There are various sizes of tubes and the endotracheal, the laryngoscope blades. Invariably, for average pain, 8 to 8.5 number tube is used. For average female, 7 to 7.5. However, half size smaller and larger should be kept as a standby for the children. Invariably age by 4+4 is the formula used, and the particular size endotracheal tube should be kept ready. Usually the size of the endotracheal tube is the of the internal diameter is of the size of the tip of the little finger, the terminal phalanx of the little fingers. The various size blade, laryngoscope blades, 0 to 0, 1, 2, 3, 4, average. The size blade for the adult will be of the 4 size or 3 size. Procedure. First, you have to assess the airway. The any abnormal swelling of the neck, cheek, mouth opening, the artificial denture, the neck circumference, degree of the neck mobility, and cervical spine stability has to be assessed. Mouth opening should be evaluated. Incisor, the length should be assessed, because small mouth opening, macrognathia, will lead to difficulty in intubation. Open the airway, suction, and do the suction. Manually extract the foreign material if at all it is present. Open the airway by chin lift and jaw thrust. If at all foreign body is suspected, Heimlich's maneuver can be used, or visible foreign body in the mouth can be removed with the Nagel's pulses. The large tongue and difficulty in maintaining the airway for proper oxygenation, chin lift and jaw thrust maneuver should be used, and if necessary, oropharyngeal or nasopharyngeal airway should be introduced. Always pre-oxygenated 100% oxygen, non-rebreathing. Or bag wall mask. Pulse oximeter should be attached, and SpO2 should be always maintained above 95%. The patient should be adjusted into the sleeping position if possible. Then for the procedure as such, the physician will stand at the head end of the patient in a supine position. The key is carried out only if the patient is unconscious, or the patient is made unconscious, or the reflexes have been abolished by induction of general anesthesia, or by very trained person when there is a difficulty in intubation, awake with a tropical anesthetization of the airway can be carried out. But in general, patient should be either unconscious or made unconscious by anesthetic supplementation, then only endotracheal intubation should be carried out. So when the patient has been anesthetized or the patient is totally unconscious, at that time, endotracheal intubation will be carried out in the following way. Physician stands at the end of the patient, oxygenate with the bag wall mask with 100% oxygen for 3 to 5 minutes. Then for the indicated intubation, and the procedure will be open the mouth by chin lift and jaw thrust. Oxygenate. Then after pre-oxygenation for at least 3 minutes, better 5 minutes, and open the mouth, oral cavity by chin lift and head tilt. Then open the oral cavity by thumb and index finger of the right hand. Insert the laryngoscope blade on the right side of the open on the right side of the oral cavity and push the tongue towards the left side and advance till the junction of a tongue with the epiglottis, that is a valleculum. Then lift the blade and lift the handle of the endotracheal tube, the laryngoscope, lift the handle of the laryngoscope forwards towards the ceiling. Do not make the fulcrum to the upper incisor. Lift, then visualize the glottic opening, the space between the vocal cords. Then negotiate the endotracheal tube with the right hand through the cords. Better endotracheal tube should be bent like a hockey stick with the stylet. Then it will help for the easy negotiation of the endotracheal tube through the glottic opening into the subglottic region into trachea. When seen the endotracheal tube passing through the cords freely, remove the stylet, inflate the cup with 5 to 10 cc of air via syringe, ventilate with the bag and oxygen, confirm the tube placement with the chest auscultation, and it is your to monitor. And in the later course, it is better to check the position of the endotracheal tubes with the X-ray chest. When it is difficult to maintain the oxygenation, we can use the artificial airways, the oropharynx or oropharyngeal airway or nasopharyngeal airway. So, as I explained, standing at the patient's head, gently insert the laryngoscope blade with the left hand. Push the tongue towards the left side of the patient. So, so, so check at advance endotracheal to the right hand through the parts. Sees the tongue, epiglottis, the junction is veliculum. The tip of the blade should come to the junction between the tongue and the epiglottis and lift the handle towards the ceiling, straight towards the ceiling. So because the muscles of the tongue are attached to the mandible, the tongue will come forwards and epiglottis will be lifted, and we can visualize the glottic opening between the, this is the glottic opening. These are true vocal cords. Between the vocal cords, you are having the glottic opening. The endotracheal tube can be fixed with the fixing device. Even though it looks so simple, it is not so easy procedure. It is associated with the complications, and due precautions should be taken to prevent the unnecessary injuries to the patient when they are carrying out the endotracheal intubation. The complication usually is missing or broken teeth. Remove the prevention is remove the loose teeth prior. Avoid using the upper teeth as a fulcrum or laryngoscope blade. Always clench this one. Full buck teeth, it will be difficult. Air liquor, check the cup prior to beginning the procedure. Whenever there may be a problem of inability to visualize the vocal cords. Proper patient positioning and a proper laryngoscope blade, proper size blade, proper suctioning are needed in order to overcome the difficulty in visualization of the cord. There, the endotracheal intubation may result in esophageal intubation. So always do the intubation after a proper visualization of the cords. Invariably, right lung intubation may be a problem. Avoid excessive tube advancement to prevent the right lung intubation. Always do the suctioning and avoid repeated attempt to intubation, so which may lead to laryngeal spasm. Spray the vocal cords with the 2% lignocaines. Failure to intubate cannot is a problem. So better get the help of the experienced senior and always carry out the endotracheal intubation with the help of a well-trained assistant. When cannot intubate, better to go back to bag mask ventilation and call for help if there is no immediate senior available, and come out of the ventilator and do not attempt repeated intubation, which may result in the problems leading to cannot intubate, cannot ventilate. And a proper training during your during your MBBS course on mannequins is essential to gain appropriate knowledge and practically carrying out the intubation during the internship period when you are posted in an anesthesia department. Management of the complication involved following the endotracheal intubation, better to have the check stretches to rule out the aspiration. And the patient should be given adequate muscle relaxants whenever there is a airway. Inject more air and change the tube over the guide wire. Smaller size tube may lead to airway. Better to change the tube. Better to change it with larger bed and this larger size tube with the help of a tube exchanger. Whenever there is a problem for visualization of repositioning, choosing the appropriate other blade rather than trying with the same blade, adequate suctioning and cricoid pressure by the assistant. Esophageal, whenever there is a esophageal intubation, immediately the tube should be removed and reoxygenated and reinsertion can be planned. And there is a problem of a right lung intubation, deflate the cup, reposition and reinflate. Laryngoscopy, benzodiazepine, paralytic agent, ventilate with the bag wall mask. Deliver to have an alternate plan prepared, bag wall mask, another type of tube, and cricothyrotomy. Difficulty will be because of the typical characteristic features of the larynx. An interior epiglottis. Epiglottis is the keystone of the larynx and must be visualized in every intubation. Two white bands passing backwards and laterally from the epiglottis. Two white bands passing backwards and laterally from the epiglottis. These are the they are white because the mucosa of the cord is applied directly to the fibrous tissue of the cords with a very little intervening submucosa. That's a vascular tissue. Lateral to the two vocal cords or the false cords, they are pink in color. Posterior knobby structure represents the protrusion of the corniculate and cuneiform cartilages. Now, all of the above features have been identified. It is safe to introduce the endotracheal tube into the triangular area between the vocal cords. So, again, to highlight the tongue, then epiglottis. Okay, these are the two vocal cords, and this is the glottic opening and white bands. Now structure cuneiform, corniculate, cuneiform and corniculate distance. Here now we got it. Trooper of false vocal cords. The two most important aspects in endotracheal intubation, position of the patient's head with respect to the thorax and appearance of the larynx. Position of the head should be adjusted, head and neck should be adjusted because there are three planes that are involved when we are going for the endotracheal intubation, which involve the tracheal plane, pharyngeal plane, and oral plane. The tracheal plane, pharyngeal plane, and oral plane. And the head is in the neutral position, thorax flat on the bed. These planes are related for this tracheal plane, pharyngeal plane, and oral plane. If we remove the redundant anatomy, and depict the planes in the stick figure form, we will get the following. That's a picture like this. The three planes are not in a straight line. Okay. Tracheal plane going obliquely down, then pharyngeal plane and oral plane. Tracheal plane is a fixed plane because it is fixed to the thorax. For intubation, we would ideally like to have the tracheal, pharyngeal, and oral planes all in one straight line. Tracheal plane, pharyngeal plane, and oral plane all should be in a straight line. Ideally speaking, for ideal position, they should be. We want to have the tracheal plane, pharyngeal plane, and oral plane in a straight line. We cannot achieve this because of the anatomy of the region, but we can get the planes into an optimal position as follows. Tracheal plane, oral tracheal plane, pharyngeal plane, and oral plane. Because the oral plane is angulated with respect to the oral plane is angulated with respect to the pharyngeal plane, we need a curved endotracheal tube to negotiate this bend. Because oral plane is angulated with respect to pharyngeal plane, we need a curved endotracheal tube to negotiate this bend. Curved endotracheal tube to negotiate this bend. Then sniffing morning air position. In order to achieve this optimal position, we need to flex the pharyngeal plane on the tracheal plane, but extend the oral plane related to the pharyngeal. What we have to do? In order to achieve this optimal position, we need to flex the pharyngeal plane on the tracheal plane, but extend the oral plane related to the pharyngeal plane. Extend the oral plane related to the pharyngeal. This is achieved by flexing the neck on the thorax and by extending the head at the atlanto-occipital. So, flexion of the neck, extension of the atlanto-occipital joint. This creates what is classically known as sniffing of morning air position. The flexion of the neck on the thorax can be simply achieved by placing a small pillow under the head. This maneuver is useful because it also prevents the head from being inadvertently extended down the thorax. If the neck is extended on the thorax and the head is also extended at the we achieve the following adverse. If the neck is extended, on the thorax and head is extended at the atlanto-occipital joint, we achieve the adverse position like this. So, again telling you, the flexion of the neck on the thorax and extension of the atlanto-occipital joint will align the three axes and it will be easy to carry out the endotracheal intubation. Endotracheal intubation helps for providing an unobstructed airway to deliver the oxygen in airway with difficulty or respiratory failure, or providing oxygen and anesthetic agents for providing anesthesia during surgery. Endotracheal tube is also used in general anesthesia, intensive care, respiratory support, and the patient requires mechanical ventilation, invasive mechanical ventilation, emergency medicine for the airway management, for polyp trauma, asphyxia, pneumonia, community acquired pneumonia. Recently, we saw the COVID infection pandemic, this one, wherein patient landed up with the respiratory failure, unable to maintain the oxygen saturation, tissue hypoxia, which will result in the metabolic derangement and multi-organ dysfunction syndrome. basically the acute lung injury or ARDS. So the skill of endotracheal intubation is a must. I think I have provided the basic idea of how to carry out the endotracheal intubation. This you have to practice on mannequins under the guidance of anesthesiologist or emergency care physicians, and gain additional knowledge when you are posted in the anesthesia department during your internship. Read and come out with your doubts or clarification you require to clear your doubts, so that you will gain confidence in managing the patients who require endotracheal intubation for the demanding situation. With this, I will end up my talk. If you are having any doubts, you are welcome. I am here to clear your doubts. Thank you.